Yeah, I think we will start. This is the SAARC Symposium. So the first speaker is Dr. G Siddesh. He is the president of the Association of Surgeons of India. And I think he was forced to go back because there is the mega conference of the ASI is going to be held within the next, I think, 10-15 days. So he was forced to go back, but he was very kind enough to present his lecture on Zoom. So Dr. Siddesh is the consultant endoscopist and the laparoscopic surgeon, medical director, Sigma Hospital, Mysore. He is the current president of the Association of Surgeons of India, and the membership is about more than 35,000. Isn't it, Siddesh?
Yes.
Yeah. Over to you.
Thank you, Narendra. And Dr. Bhavantav, I can see you on the desk. And I hope my co-panelists have joined in as well. So I bring greetings again from the Association Surgeons of India. And thanks immensely for giving this opportunity to share some of the views on this platform where we are meeting up for a SAARC symposium every year. And we are going to have a similar one during our ASICON at Mumbai later on in December this year. So this SAARC summit or the group of associations has taken off very well, and we are progressing very strongly with the aim of coordinating for the improving the knowledge as well as improving the better facilities amongst ourselves. So always it is a sharing is caring. So with this, I would like to share some of my views. I have chosen a topic of the changing trends in surgical practice, which is quite relevant to all the countries all over the world, as well as especially particular to this part of the world where we are now practicing surgery as SAARC countries. We all know who all make up the group of general surgeons. Without going to that, over centuries, surgical profession has set standards of ethical and human practice. Many landmark accomplishments in the science and innovations have occurred both in techniques, and they have revolutionized the surgical care, which you all agree. General surgeons have developed, practiced, and passed on the legacy to the next generation over many decades. Beyond science and art, surgery is uniquely fulfilling as a profession, which you all really are proud to profess and practice. In return to this practice, surgeons have been given a due respect in the society. But there is a thought that this respect in the society is fast deteriorating. Is it true? And that if it is happening, what are the causes? Let us just look at these changes. From the turn of the century, there has been profound changes which have occurred at various levels of surgical practice. And these changes not only have provided challenges, but also have provided new opportunities to give a better patient care. We all are aware about the aging population, which has contributed to diseases of the chronic nature. Gender composition among the surgeons, which was also of the topic of discussion when I was there yesterday in Sri Lanka. When I joined in 1975, my MBBS course, out of the 103 in my class, we had 13 girl students who joined in along with us. Whereas today, if I see, when I go out to travel to teach the postgraduate students, I can see the composition of the residents in any conference where the girls form nearly about 50%, if not less, of the total share of the surgical residents. There has been a significant change though, and this also what will happen is the choice of the patient preferences will also go on changing. So that is one of the changes which you need to keep in mind when we train our surgeons. Market-driven healthcare has become a new pattern. Healthcare is seen as a profiteering enterprise, no more as a service enterprise. But we need to remember any such change should be backed by evidence, otherwise we'll be facing danger. That is my opinion. Even the choice to become a surgeon, I can find over the last decade, if we go by the ranking in the post counseling following the entrance exam for postgraduate studies, we find that the initial preferences, which used to be surgical specialties, have gradually weaned away. If we just think back what could be the cause for this lack of interest in the young generation to become surgeon, there has been an emerging feeling among new graduates that surgery is a specialty which is associated with a lot of stress. And they also feel there is a many years of training is required before they can start earning. Litigation rates are going up. These are the apprehensions probably are leading to this lack of taking up surgical specialty. My talk in the next few minutes would be covering this. Changing pattern of the diseases, if you know, is mainly associated with lifestyle modification, which has added to the problem of medical care all over the world. And it also adds to the economic burden of healthcare of every country. If you go by the statistics which is provided recently by the WHO, in the year 2005, these chronic illnesses associated with lifestyle changes were up to contributing to 49% of the total illness, whereas the causes of death out of that would be around 61%. But the WHO has looked up with the changing trends that by 2030, the estimated chronic illness contribution would be up to 56% and beyond, and death may be even beyond 70% of the total. You look at the individual diseases. When I was a medical student, I could see a long list of peptic ulcer disease as a major component of the surgical unit list on any given day. And today we know, because of the better understanding of the disease, and we know the etiology, infective etiology of the peptic ulcer, it has gone out of surgical domain for treating peptic ulcer, except for a few emergencies. Likewise, we see, again, when I was getting trained as a surgeon, gallstone disease were a rare entity, especially in South India. Now, today, after coming back from Sri Lanka today early morning, I have finished 3 laparoscopic cholecystectomies, including 1 empyema, and there is one more waiting for me for this present day. So that being the composition of the surgical practice of gallstone disease today in our day-to-day practice. So there has been a significant change in the pattern emerging, and we can always attribute this again to the lifestyle changes and dietary habits. But I am proud to say, being a surgeon and also performing therapeutic endoscopy, we do come across such complicated bile duct stones and numerous stones. They can be managed in our hands by doing ERCP. So take this opportunity to earnestly recommend the young surgeons in the crowd here to take up endoscopy in their practice if they are not doing it right now. Even large stones like this can be handled by surgeons by ERCP. And we are blessed with the skill of performing laparoscopic CBD exploration if the stone is not amenable for endoscopic treatment. So that is why I believe surgeons can give a comprehensive management of the gallstone disease. We need to look at this. This is one of the emergencies which came when I was in Sri Lanka. My assistant put it up like this. The patient, forget about we offering a treatment by a general surgeon. The patient was asking to be treated by a hand surgeon, a surgeon, like plastic surgeon who is specially trained. So the awareness among the general public there has been a significant change because of the available information at various platforms. So earlier days, we were very well trained and equipped to treat these illnesses at the hands in the Department of General Surgery. Further, I would add, with the need of metabolic and obesity surgery and increased awareness for cosmetic surgery, our young surgeons need to be aware about getting trained in these procedures as well in their practice. Development of subspecialties have really run into the practicing general surgeons. Today, I saw yesterday in the program, there was interesting discussions on thyroid and other head and neck diseases in the general surgical platform. But I see even in India, large number of ENT surgeons have started practicing thyroid surgery. And not only that, even the oromaxillary and facial surgeons, they claim they can also perform thyroid surgeries. So there is a changing scenario now. We need to meet up with these new challenges. Technological advances, though there have been many, especially in the field of minimal access surgery, advanced imaging, therapeutic endoscopy, robotic surgery, and navigation technology. So they are there for us to treat the patients at hand with better capacity. But they should not be used as a burden to the patients and also to the healthcare system. Yesterday, I found the chief guest of the evening in the inaugural function of yesterday's meeting at Sri Lanka. I could find a very interesting mention on this, that we need to evolve a reason where we can use these new technologies cost effectively and restrict their use to the absolutely necessity of the patients, not generalizing their usage. And another issue which I look at when you look at the technological advances, we are fast losing the human touch. Artificial intelligence is only an aid, but not an alternative to clinical medicine. Training, we used to believe in, being Indians, we believed in the training pattern of Gurukul, where we used to find an idle surgeon whom we found to follow, like my guru, Dr. B.N. Shrikande, whom I always look up to him, even at this age, for advice and any part of my difficulty, to look up to him for his advice and guidance. But is it that this pattern is dwindling now? The mode of training, because of the increasing number of the postgraduate students, I was the only guy as a postgraduate student in my surgical unit when I joined in that particular year. Today, each unit, I'm sure there will be 3 or 4 postgraduates who get added onto each unit's work. So there is a sharing of the knowledge where the skill enhancement becomes difficult. So we need to resort to newer technologies in training, including the virtual reality, augmented reality, simulators, and cadaveric labs. Hence, there is a need for establishment of skill centers in all medical schools. This is one of such facility existing in a medical college which I visited. The other change which we see in the practice is the dwindling trust between patient and the surgeon. Surgeon shopping has become more common. Social media has contributed immensely to this as well. And bashing up of surgeons, physical assault has been seen quite often in India right now, and it is in a big news. We need to be aware of this, and we need to meet at association level, discuss and try to find newer ways of avoiding this problem. Marketing has reached different methodologies, and that may be one of the reasons why we are facing the newer challenges of dwindling trust, because medical care is being looked at as a profiteering enterprise and not as a service. Pandemic also has given us newer dimensions for thinking in the patient care. But teleconsultation and teleeducation, now I'm sitting in Mysore delivering this lecture, is a new facet of communication which we can use it very effectively even in the patient care. I would recommend by technological orientation during the surgical training should be a part of the curriculum. Training in endoscopy should also be a part which, as an association, we are taking up the issue with the National Medical Council to include it in compulsory, as a compulsory PG curriculum. We want to hold certified programs under the association to train surgeons in endoscopy. Likewise, ultrasound training should become also a part of our training, which is because the advantages associated with it. Better coordination is required between institutes where there are centers of excellence in certain fields where we can always do these exchange programs, can do a better training. We need to interact with other associations in the society. Like in Mysore, we Association of Surgeons in Mysore city level have also become a member of Federation of Organizations, including several business enterprises, where we have several things which are in common, but also this can clear some of the doubts which can exist in public by and large. Some suggestion to the young surgeons, I would suggest they start taking up a special focus training in emergency and cosmetic surgery in addition to the wound management. For surgeons who are practicing in remote areas, multitasking and establishing a network where they can find somebody who are available to fall back either by teleconsultation or telementoring, we can call, that should be having a clear pathway to fall back in case of difficulty. But with all these challenges, I would say in the final word, we need not lose hope. Nearly 5 billion people still cannot access to safe surgery for their illness. 143 million surgical procedures are required annually to be done. Surgical specialty, if given a boost, can make society more productive. Realize it is a time to realize the strength in us to make the change in the economy of our country where we live and for ourselves. In conclusion, surgeons not only can add years to life, but add life to years. Be a part of the change rather than fighting it, but understand the change early so that you can adapt to it. But lastly, go by the evidence before jumping into the new. ASA has been contributing in several ways to meet these challenges and the changes which are occurring over years. And that is the place where I do practice, Sigma Hospital at Mysuru, where I'm right now sitting. And that is the illuminated palace of Mysore, which is really an enchanting view to look at. I invite all of you in your next visit to India, please make a point to visit Mysore. I would be ready to host. And these are my contact details. Thank you very much again for allowing me to share some of my views. I'm open for discussion. Thank you.
Dr. Siddesh, for that interesting lecture on the evolution of general surgery and the change in trends of surgical practice. He is from the land of Maharajas and sandalwood, isn't it? Thank you very much.
Yeah. Thank you. Thank you.
Yeah, we will keep questions towards the end of the session,
At the end.
Dr. Ganesh. Yes.
Okay, fair enough.
Yes.
Thank you.
Yeah, thank you very much. And probably in a few weeks' time, we will be joining in ASICON with all of you there.
Sure, Mumbai.
Right, Mumbai, yes. Our next speaker is no stranger to us. He is other than Professor Abdul Majeed Chaudry. He is the principal and chairman Department of Surgery in Lahore Medical and Dental College, Lahore, Pakistan, and he has been with us for many, many years and coming to Sri Lanka many times, and he's one of the live wires of SAARC Surgical Care Society. So without wasting much time, may I invite Professor Chaudry to deliver his lecture on disaster management, SAARC perspective. Over to you, Professor Majeed.
A very good afternoon, ladies and gentlemen. I bring greetings from Lahore, Pakistan. And, I'm grateful to the organizers, sir, for inviting me here, which is like a second home now. I've been visiting it, Sri Lanka for the last about 14 years. And I was honored with a fellowship of the college a few years ago. And thank you very much for providing me an opportunity to talk to the audience here. Ladies and gentlemen, I chose this topic, disaster management in developing countries, because I'm sure you all know recently we had a flood disaster in Pakistan, and it was absolutely devastating for the whole nation. Disaster can be defined as any occurrence that causes damage, ecological disruption, loss of human life, and health services on a scale sufficient to warrant an extraordinary response from outside the affected community or area. And some disasters can be predicted, whereas others can't be. Going back to Hurricane Katrina was one of the turning points, not only in the lives of people of Louisiana, but New Orleans, but also for the American politics. Within days of the hurricane that hit US on 29th of August 2005, criticism started on delayed evacuation. Images of hungry masses flooded the electronic media, and televised interviews of shaken and frustrated politicians were on the air. There was a lesson to be learned by for the South Asian countries as to how poor disaster management may lead to political instability, and something we all can't afford. These days, the Mina tragedy in holy city of Mecca, where thousands of lives were lost, has not only turned into a hot debate on disaster management, but is taking political turn in the mighty arena of global politics. That's the power of disasters in today's vulnerable world, where crisis management and disasters and emergencies are tied together with economic, political preferences, human security, and overall resilience of the government. Kashmir lies in the area of collision of Eurasian and Indian tectonic plates, and the geological activity born out of this collision is also responsible for birth of Himalayan mountain range, is the cause of unstable seismicity in the region. Pakistan is vulnerable to new natural disasters in the form of earthquakes or recurring floods, health crises like dengue spreading quickly these days, and energy crisis and man-made disasters like terrorism and bomb blasts. In 2005, there was an earthquake of the magnitude of 7.6, and the areas affected were Pakistan, India, Afghanistan, and there were 69,000 casualties and 2.8 million people were displaced. And these are some of the pictures of the disaster of 2005, and unimaginable. Now, sustained economic growth and daily life activities have a direct hit from any disaster or crisis, especially when unprepared. You know, I'm sure even in Sri Lanka, but in our country, armed forces are the first responders to any natural disaster of a large magnitude due to their well-coordinated strategy and expertise. In 2014, heavy rains in northern India and Pakistan resulted in widespread flooding. In Indian Jammu Kashmir and the Pakistan province of Azad Kashmir, Punjab, Gilgit-Baltistan, and Khyber Pakhtunkhwa, later Sindh province. And, and there were 277 deaths in India at that time and 280 deaths in Pakistan. And, 367 people died in the disaster. Over 2.5 million people were affected by flooding from over 4,000 villages, and nearly 70,000 people were evacuated, and floods left over 100,000 homeless people where their homes were damaged, and livelihoods were also damaged, in particular agriculture. These are some of the pictures from floods in 2014 in India, and look at the calamity, the magnitude of the calamity. And ladies and gentlemen, unfortunately, we have been facing man-made disasters as well in this part of the world. And in 16th of December 2014, in city of Peshawar, there were terrorist attacks in Army public school, and 126 innocent students died as a result of that. Honestly, very, very heartbreaking. And although these culprits were taken care of and they were killed at the site, but I think it has left a very lasting damage to our minds of that incident. And lately, in Pakistan, we had this, this was a scene of unloading from the honeymoon hotels. They were just cautioned in time, and look at the disasters of 5-story building just crumbling to the floor in no time. And similarly, a lot of other hotels were, absolutely disastrous pictures. Luckily, there was not a great deal of human loss of life. But now, I wanted to share some of the interventions that we have done in Pakistan. And I think we should learn from each other. We have this special authority after 2005 earthquake, which is called Earthquake Reconstruction and Rehabilitation Authority. And the second one is National Disaster Management Authority. And then we have got a very, very good ambulance service in whole of the country that is called 1122. And any part of the country, they will reach at the site in 6 to 7 minutes at the most. And of course, armed forces, they are well equipped to meet such kind of disaster to help their nation. In this Reconstruction Authority was established in 2005 after the 2005 earthquake. And and its function are to act as the implementing, coordinating, and monitoring body for disaster management, to prepare the national plan to be approved and implemented, coordinate and monitor the implementation of the national policy, and to coordinate responses in the event of any threatening disaster situation. This was the 4th consecutive years of high-impact monsoon rain in Pakistan. and the flooding has killed hundreds of people. And there was this latest flood disaster, I'm sure you must have seen on the media, that 33 million people were rendered homeless, which is about nearly 1.5 times the population of Sri Lanka. And 3 months down the line, would you believe that still most of the areas are drowned? And still access to many affected areas is not possible. And scores of villages were wiped out of this scene. This management, we have another disaster management authority, is essentially an autonomous body and constitutionally established disaster preparedness. Federal institutions mandate and responsible to deal with the whole spectrum of disaster management and preparedness in the country, because that's very important. You know, we have been having the experience of these disasters for decades now. You know, it enforces national disaster policies at federal and provincial levels and collaborated closely with various governments, ministries, military forces, and United Nations-based organizations to jointly coordinate efforts to conduct this disaster management. You know, it aims to develop sustainable operational capacity and professional competence to undertake its humanitarian operations at its full capacity. This is the service that we had. We are very proud of it in whole of the country. Anywhere in the country of a population of 220 million, you know, this rescue service is available, not just the ambulances, but even otherwise. You know, in this flood disaster recently, we had 2.5 million acres of crops which have been lost, and 9,000 cattle perished. You know, our agencies do have international collaborations as well. The National Disaster Management, you know, and help government of Nepal in dealing in 2015 the Nepalese earthquake. And, you know, in various forms of human resources and other facilities like blankets and tents. And so this is an organization which stays well prepared in wake of any disaster in the country or in the neighboring countries. You know, this is what I think were some of the pictures of the disaster of in Nepal. And ladies and gentlemen, I think now, since you know we have been experiencing these disasters over the last many decades, I think there should be introduction of disaster management at the higher university level, with curricular changes where organizations can help input on practical aspects of the field, and military can train government human resources for effective response mechanism. The role of media can be a partner in highlighting the needs and awareness about disaster risk reduction and educate masses, and they should avoid sensationalization. Ladies and gentlemen, in conclusion, let's all pray to Almighty and all the gods to have mercy on our planet and all the human beings. Nobody has any control on natural disasters, but we can always be prepared to meet such disasters and reduce the loss of human life to the minimum. Another thing that I would like to add is, I wish, you know, the SAARC association of these countries could perform better. You know, it should have been an economic forum. It should have developed mechanisms to help countries where, we were hit economically. And, just on the lines of European Union. And I think we need to forego our differences and work for the betterment of humanity in this part of the world. Ladies and gentlemen, I thank you very much for your kind attention.
Thank you very much, Professor Majeed, for that excellent presentation. And as you all know, if we get together the SAARC countries, there's a lot of training can be done when we joined each other. And I think founder, president of the SAARC Surgical Care Society is in the audience, Professor Arjuna Vihare. I think that is one of our objectives of having the SAARC Surgical Care Society. So thanks once again, Professor Majeed, for your excellent presentation.
I think we have to, Bhavanta, we have to thank him again for the donation of many surgical instruments to the several hospitals, as well as, this time he has brought some more, another stock of surgical instruments from Pakistan. Thank you very much. The next speaker is Dr. Sunil Kumar Sharma, consultant gastrointestinal and laparoscopic surgeon. He is the head of Department of GI and General Surgery, Medicity Hospital. He is the president of the Society of Surgeons of Nepal, and he had been honored with our honorary fellowship of the College of Surgeons of Sri Lanka. And over to you.
Good afternoon, chairpersons, ladies and gentlemen. First of all, greetings from Nepal, and thank you very much for giving me this opportunity. I would like to thank the Sri Lankan College of Surgeons and the SAARC Surgical Society for giving me this opportunity to talk to you all. I'm especially honored also because the stalwarts of all of this, Professor Alu Vihare, who is not only a famous person in Sri Lanka, but is very well known in Nepal as well, is amongst us to listen to my small two-piece knowledge. Now, I'm going to be talking something extremely different from what you've been hearing so far during the last 2 days as well, where we all have to been saying that we have to be compassionate surgeons. Now, my belief is the most important part of compassion is actually safety. And when you sit on the other side, you've just heard Professor Siddesh talking about what is happening to our fraternity and how we're getting demoralized. But when you look upon it from the other side of the bench, it's a completely different story. And are we ready for that? Are we safe as a profession? Are we willing to be honest with ourselves? And I think that is most important. I dedicate this talk to my sister-in-law, Nisha, who never woke up in the post-operative ward. Her 2-year-old and her 5-year-old keep asking me every now and then, what happened? My cousin lost his soul partner. Nisha went in for a routine incidental hernia surgery. The anesthetist failed to put an epidural for pain. She didn't have a very big surgery. She had a TAR procedure, but the post-operative arousal was slightly delayed. In the post-operative period, she complained of pain. Within a span of 10 minutes, 2 anesthesiologists ordered IV fentanyl without cross-checking. A faulty cheap monitor didn't pick up the hypoxic period. She suffered hypoxic brain damage. She never woke up. Whose fault is it? I think it's multiple levels. But what about the surgeon? Am I to be blamed? Well, unfortunately, as Nisha's mother said, because you're the captain of the ship, you have to take the blame partially. Now, this is what I'm trying to bring about awareness among us. We've got to understand, as Emily Dickinson said way back in 1859, the surgeon must be careful when he or she takes the knife, because underneath that fine incision stirs the culprit, life. If there was no life, we could play around as much as we wanted. Or this famous saying that all of us have read in Bailey and Love, from inability to live well alone, from too much zeal for what is new, and contempt for what is old, from putting knowledge before wisdom, science before art, cleverness before common sense, from treating patients as cases, and from making the cure of disease more grievous than its endurers. Good Lord, deliver us. Or as Mahatma Gandhi said, now this is something we must all recognize. It is unwise to be too sure of one's own wisdom. It is healthy to be reminded that the strongest might weaken and the wisest might err. I will come to this article by Leap in 1994, but I thought his conclusion is beautiful as far as surgical negligence is concerned. Physicians and nurses need to accept the notion that error is an inevitable accompaniment of the human condition. Even among conscientious professionals with high standards, error must be accepted as evidence of system flaws rather than character flaws. But as surgeons, we have made efforts to bring about change in our character flaws, but we have done nothing to bring about change in the system flaws. Now, this is a very interesting article, The Global Burden of Postoperative Deaths in Lancet, and you'll be very surprised to know that we are the third cause of deaths in the world, worldwide. If you look at postoperative deaths, we are number 3. So though we think we are here to cure, we actually cause more harm than what we want to believe. So what do you think is the estimate deaths due to medical errors? If you look at the incidents from America, and this is not very long back, it's in 2018, the source is the Philadelphia Inquirer, 3 times more deaths due to medical errors than motor vehicle accidents. Now that, my friends, is very alarming. And this is the article from Leap, which says that we are the most dangerous system of any delivery in the world, the healthcare system. We are as dangerous as mountain climbing and bungee jumping. There are 7 centers for bungee jumping in Nepal, and there are plenty of mountains you can climb, but you hardly hear somebody dying of bungee jumping or climbing a mountain. But every now and then you'll hear an incident in the paper of something that's gone wrong in the hospitals. So why is this happening? I take you back to a very old article from Shockford in 2002, because this is a milestone article which actually tells us and divides types of adverse events. There are 5 types as he describes: judgmental, technical, expectational, systemic, and mechanical. But more importantly, he divides deaths into 3: non-preventable, potentially preventable, and preventable. I'm sharing with you some of the examples in my 25 years of career that has happened to me and my colleagues with these kind of deaths. An 18-month-old child, healthy otherwise, diagnosed with bilateral hernia, a straightforward herniatomy, a highly experienced pediatric surgeon, ASA grade 1. The anesthetist had more than 20 years of experience, but the child never woke up. Was it a cardiac event? Was it some sort of anomaly? Or was it the nurse, the anesthetic nurse, who gave the wrong drug? We will never know, because in our part of the world, I know it must be the same in Sri Lanka, postmortems are something that families don't want. So this is something I don't think that could have been preventable, or maybe it could have been preventable. What about potentially preventable? A 69-year-old hypertensive, last 20 years, she had dyslipidemia, but her hypertension was under control. She underwent a simple lap cholecystectomy, general anesthesia, discharged the next day. She was uneventful till day 3. Day 3, she came in collapse, readmitted, diagnosed as massive ventricular bleed, and died on day 4. And the reason was, in her discharge summary, they had forgotten to say, please continue your antihypertensives. Again, another preventable. 60-year-old lady, hypertensive, ASA2, diagnosed a carcinoma stomach, did a D2 gastrectomy. She, on the first posterior day, during the rounds, I noticed that there was blood in her urine. And she was in the ICU. Blood transfusion was going on. Stopped the transfusion, started all protocol for mismatch reactions. On inquiry, hematuria had been occurring for the last 6 hours. Patient died day 3, completely anuric. Following a total gastrectomy for a 46-year-old male, ASA 25, a circular stapler was used for esophageal jejunal anastomosis. On day 2, I noticed bilious drainage in day 1. Intervened immediately. There was total failure of the stapling device. I contacted the company, and it was a new company, and he said it was he apologized to tell me that the batch was faulty. I went in, did a redo with a colonic interposition. Unfortunately, the patient developed ARDS, died day 34. Now, you may think maybe this happens only in our part of the world, or maybe only in Nepal where we are not so rigorous. Wrong. This is from Virginia, a high volume center, and this is in the annals of surgery, and if you look at their 30-day postoperative mortality, 20% of their postoperative mortality is due to adverse events. And if you look at the 20%, 4.2% are certain errors done by the medical staff. 8.4% is likely errors, and 6.7% is errors could have happened. So that's how bad we are as treating physicians all over the world. Now, in my opinion, this is the most important slide of this whole talk of mine with the last 30 years of experience. You are as strong as your weakest link. We are a chain. As surgical providers, medical providers, we are a chain. We need to reflect on the factors and the faculty of the chain. We, as doctors, feel we need to increase our dexterity. We go for simulation courses. We go for fellowships. We study. We work hard. We make sure that we are strong. Yes, as a surgeon, you've trained, you are strong. But what about the nurse on the floor, the OPD attendant, the person who's cleaning up your ward, or even the patient who's transferring or the person who's transferring your patient, or even your house officer? Are they equipped with the same knowledge, the same skill as a surgeon? And can you only blame them, or does the blame come to us? Unfortunately, the blame comes to us. And that is why our profession is going down with dignity these days. Now let's talk about adverse events. Most of us pretend that it never happened. Wrong patient, wrong side, wrong surgery, inadequate surgery. It happens to all of us. And when I say all of us, most of you have heard of the famous story of the South Indian actress Sridevi's mother being operated on the wrong side. But look at the incidence of wrong side surgery among hand surgeons in America. They looked into 168 surgeons, and they found out that 21% of them had operated on the wrong side sometime or the other. Then they started the Sign Your Sight campaign, and when they did that, it was brought down so drastically, and when they looked into it, 45% of the orthopedic surgeons, hand surgeons, had actually changed their practice and had started practicing this. So protocol, simple protocol, will bring about the defect that can go wrong with our patients. Now this is something very close to home. It's an article in 2017 by Raja, Never Events in Surgery. Is it just an error or an avoidable disaster? And he attributes these 4 things for disaster that happens in surgery: human errors, communication errors, that is most important, system failures, and equipment failures. Now, again, I'm going to give you some adverse events that I've had to go through. During a routine LAR of an 86-year-old patient with an ASA 2, I asked for a 29. I got distracted, and the operating team didn't reconfirm with me and opened a 31. And you know, in our part of the world, once the seal has been broken, you can't give it back. So I had to do it with a 31. I had difficulty in anastomosis. The patient landed with an ileostomy. The patient survived. But the question is, the patient went through an ileostomy for a straightforward LAR that really didn't warrant one. And that's just because the nurse did not confirm. Now, there's a story that happens to all of us surgeons. I was doing a Whipple's procedure, And as you know, I take around 5 to 6 hours, and then the nurse team changes. They go home. The swab count went wrong. We did a CM, re-explored it, everything was done. Finally, we didn't find the count, the swab. 3 hours later, the main nurse was contacted, and she said, yes, there was one swab missing. And it was a correct count. But the total anesthesia for the patient was 3 hours more. Who is to be blamed? Following a THE for carcinoma of esophagus, this is very early on in my career when I first came back to Nepal. I used to use a Foley's for my FJs. The nurse fed the patient through the balloon compartment of the Foley's. The patient leaked due to distal obstruction. I realized it immediately, averted it. I put her on TPN and conservative methods, and the patient stayed in the hospital for almost 26 days before I could discharge her. So what are the causes? Number one is ignorance. We do not care to teach what we are practicing to our others. And when I mean others, it could also mean the hospital management. These days, more and more hospitals are being managed by healthcare by personnel who have no knowledge of what goes on in taking care of a patient. That ignorance has to change. It's egos amongst us, egos amongst nurses, paramedics, by not wanting to say, I do not know how to do this. It's our culture in South Asia not to question, and that has to change. There's lack of protocols, and the compliance for safety is very low. So this is my Nepali study. I sent a questionnaire last 5 months to 1,700 bedded hospitals within the capital. Only 11 of them responded. And ours is the only hospital that is what is known as National Accreditation Board Hospital. So we are accredited by the National NABH in India. Okay, I'm going to finish quick. So if you see, that's the hospital I work in. We have a lot of things, but nursing empowerment is the most important thing that has brought down near misses by 26.8%. and drug inoperation by 11%. So the solutions, there are plenty, but the one that I put in bold is data. We've got to start maintaining our data, and then we'll come to the solutions. So what have we done to improve patient safety? We've conducted 4 international conferences. We've developed a smartphone app. We're lobbying with the council, and we've now got a standard and accreditation committee formed under the Medical Council of Nepal. So the take-home message is, let's practice safe surgery, change our culture, put a cover over our egos, start the WHO checklist, must have protocols, build a culture of disclosure, and strengthen our weaker links. Thank you very much for your patient hearing.
Thank you very much, Sunil, for that important lecture on patient safety and highlighting that how vigilant we have to be to safeguard our patients.
Yeah, our next speaker is Dr. Buddhika Dassanayake. He's a senior lecturer and consultant general surgeon with special interest in hepatobiliary surgery. So the topic is very interesting. The general surgeon in Sri Lanka, endangered species or invasive species. Unfortunately, there are not many general surgeons in the audience, but hope. Over to you, Buddhika. I don't want to waste time. So.
Thank you very much, sir, and I'm honored to be representing Sri Lanka at this symposium. Moving on to the topic for the day, I'm going to talk about this topic, and I'm going to leave it as an open question. So we'll start with a brief introduction to the postgraduate training for surgeons in Sri Lanka. It's a bit unique. Being a small country, we have one institute responsible for sole qualification and training of all medical postgraduates, the Postgraduate Institute of Medicine, which was established in 1980. Prior to this, surgeons got their FRCS, joined the state service. The PGIM started board certification of surgeons from 1980. At present, the PGIM has over 22 boards of study, over 40 specialty boards, and in surgery, the training period requires 5 to 6 years of training in Sri Lanka, followed by a mandated period of 1 to 2 years overseas. So a surgeon may join the Ministry of Health after board certification, a university surgical unit, or work in the private sector. But in the Ministry of Health, it is the ministry that decides where the surgeon is appointed to and what role the surgeon has to play. So when the PGIM started in 1980 with that small building, surgery was one of the 12 recognized specialties that was offered. But the general surgeon prior to 1980 had a very vast array. He had to be the orthopedic surgeon, he had to be the urologist, he had to be the pediatric surgeon, he had to do a trauma flap and do burr holes for evacuation of an EDH, everything. But as the armamentarium of the surgeons improved, as the knowledge bases improved, understandably subspecializations had to be brought in to improve the quality of service. So orthopedic surgery received its board certification in 1986, and slowly the slices of the pie started to be removed from the general surgeon. Neurosurgery came in, ENT, urological surgery, vascular, pediatric surgery, surgical oncology, plastics, gastrointestinal surgery, thoracic surgery. So what would the general surgeon be left with? Would it just be an appendicectomy and draining of an abscess? Would it be just the hernia? So the issue is quality of service has to improve, specializations have to improve, and the general surgeon's role as the casualty surgeon in all the hospitals in Sri Lanka had to improve along with this. And so the issue came of adding value to the degree in general surgery. And the method of adding value was adding a special interest. Every general surgeon would be board certified as a general surgeon, but they would all have to declare a mandatory special interest in either upper GI surgery, lower GI surgery, HBP, vascular, breast, endocrine, or trauma. And this was a very well-meaning initiative aimed at adding value, but the only issue was that the board certification remained in general surgery, not in any of these special interests, as it were. So the general surgeon, who had separated roles now from the plastics, GI surgeons, vascular surgeon, slowly with the special interests starts to encroach. And there is a certain overlap with oncosurgery, because the breast reconstructions are taken over by the general surgeon with special interest in breast surgery. There are general surgeons with special interest in vascular surgery. Thyroids may be shared with an endocrine surgeon and an ENT surgeon, so on and so forth. And invariably, conflicts start to arise. And so the question arises, does the general surgeon meet the definition of an invasive species, an organism that adversely affects habitats, bioregions, causes economic, or in the case of the private sector, even economical damage to the rivals? So perhaps the general surgeon shares some attributes here with the cane toad in Australia, with Salvinia in Sri Lanka, when it comes to meeting this definition of the invasive species. Along with these conflicts come another set of challenges that the general surgeon faces. Training in Sri Lanka and overseas now has to be matched to the special interest. A general surgeon would initially train overseas in some area and bring back that special interest. But now they have to match that special interest, and finding an overseas training slot, which is mandatory for your board certification, is harder. We have already talked about the conflict with specialities. The general surgeon also has to handle the burden of casualties on calls, which many of the specializations do not need to handle. And also, the Ministry of Health does not exactly converge with this business of special interests, because it still follows a seniority-based policy of mandatory 4-yearly transfers for all general surgeons. I'll describe the issues that occur with this later on. And we'll talk about how poor job satisfaction and migration is also compounding this issue in Sri Lanka currently. So let's say there are 4 hospitals in 4 areas in Sri Lanka, and one general surgeon with special interest in HPP surgery is appointed to one place, one in vascular surgery to another, one in breast surgery to another, one in lower GI to another. So they have to develop their special interest. They have to order relevant equipment from the ministry. Perhaps the HBP surgeon will order a side-viewing endoscope and start ERCP work. The vascular surgeon will order grafts. The breast surgeon will order methylene blue and start sentinel node biopsies. The lower GI surgeon will order a colonoscope. And they will improve their special interest services. But cometh the fourth year, the ministry will transfer these people around. So the HBP surgeon will end up with methylene blue. The breast surgeon will end up with a colonoscope, the vascular surgeon will end up with a side-viewing endoscope, and the lower GI surgeon will end up with aortic grafts. And this policy does not converge with the intent of the Postgraduate Institute of Medicine. And that's one issue that general surgeons are facing at the moment. The other issue is what one of my trainers used to call regional ignorance. General surgeons have to do casualty on calls, unlike most specialized units. And since accident and trauma services are not widespread in Sri Lanka, the general surgeon is most always the trauma surgeon. Now, we all know that doing countless surgeries for femoral hernia, one hardly ever sees the femoral vein. Doing plenty of surgeries on the saphenofemoral area, one hardly sees the femoral canal, one hardly sees the femoral artery. But a vascular surgeon would see the femoral artery, but perhaps not see the femoral canal where the hernia comes through. But when you get someone with a stab to the femoral region, someone who focuses on one area is sometimes regionally ignorant and would probably provide a poorer trauma service than someone who is exposed to the area. A surgeon who operates on a cervical rib as well as a thyroidectomy and a cervical block dissection might be better versed at treating a stab to the neck than someone who only focuses on the thyroid. So when every general surgeon is required to be a trauma surgeon in peripheries, the issue of whether the special interest hinders care or not also comes into place. We did a survey a couple of years ago on trainee satisfaction with general surgery and special interests. The results were not very heartening. Only half the trainees in special interest seemed to be happy with their special interest training. They believed that the opportunity to function in the special interest was very limited in the current employment structure, and therefore they doubted whether they would have a career benefit in taking this up. And also, this article from 2013, way before the economic crisis in Sri Lanka, showed that Sri Lankan medical specialists are migrating at an alarming rate, and that if you take the separate specialities, you will notice that the highest percentage of migrants from the health sector in specialties are the surgeons. General surgeons and other specialties account for 21%, which as one sector is the highest specialty for migration. And with the current economic crisis in Sri Lanka, migration is occurring at an alarming rate. And over the past 6 months, we have had skyrocketing in migration overseas for greener pastures, perhaps where the skill set that they have earned is better put to use. Which brings us to the end of this very short presentation. An endangered species is a species that is very likely to become extinct in the near future, either worldwide or in this case, in a particular political jurisdiction. Perhaps because of habitat loss, such as facilities, perhaps because of poaching, such as in the private sector, or perhaps because of invasive species. So the question is, do we share more in common with the pandas or the cane toads, more in common with the sloth bear in Sri Lanka or Salvinia? So where is the general surgeon really? Is he invasive or is he endangered? I'm not going to answer that question. I will leave it to you to ponder. Thank you very much for allowing me to make this brief presentation on behalf of Sri Lanka.
Thank you very much, Buddhika, for that excellent presentation. However much we work, as long as the patients are not endangered, I think we should all be fine. So let me conclude this symposium by thanking all the speakers on behalf of SAARC Surgical Care Society. And SAARC Surgical Care Society is compiling a textbook of SAARC region. I think Professor Chaudry is editor, so hopefully our trainees and surgeons will be able to read it next year. Thank you very much for all the speakers. Thank you.